Hello again, all, and welcome to the Science of Childhood Cancer lecture series hosted by the St. Jude Comprehensive Cancer Center. I'm Dr. Melissa Hudson, co-leader of the Cancer Control and Survivorship Program at St. Jude. On behalf of myself and my co-program leader, Greg Armstrong, we welcome you to the fourth week of this 15-week series. The Science of Childhood Cancer is a weekly virtual lecture series designed to engage the scientific community on key questions in pediatric cancer research. Lectures cover a range of exciting topics across the spectrum of basic, translational, clinical, and population sciences and cancer survivorship. This virtual series was initiated during the time of COVID and has engaged more than 5,000 registrants as of this week and attendees from all over the world. We are now in the fourth week of the spring series. It's my pleasure today to welcome Dr. Robin Yabroff from the American Cancer Society. Dr. Yabroff has kindly offered to stay for some time after the official close of the event at the top of the hour if anyone would like to stay for further discussion. And now I'm pleased to introduce Dr. Yabroff, who is an epidemiologist and scientific vice president of health services research at the American Cancer Society. She conducts research on financial hardship and the economic burden of cancer, patterns of cancer care, including high-cost prescription drugs, health insurance benefits design, and patient, provider, and system factors associated with quality and value of cancer care. Dr. Yabroff has more than 20 years of health services research experience and has held positions within the Office of Health Policy, Assistant Secretary for Planning and Evaluation in the U.S. Department of Health and Human Services, the Health Services and Economics Branch of the National Cancer Institute, and the faculty of the Lombardi Cancer Center at Georgetown University. Dr. Yabroff earned her PhD in epidemiology from the Johns Hopkins School of Public Health and received an MBA from the University of Rochester. She has adjunct positions in the Department of Medicine, the Johns Hopkins University and Department of Health Policy and Management, Rollins School of Public Health, Emory University. Dr. Yabroff has co-authored over 200 peer-reviewed journal articles, editorials, and book chapters. She's a frequent speaker at national and international scientific meetings and serves as an associate editor for the Journal of the National Cancer Institute. She's also a member of the editorial board of JCO Oncology Practice in the Journal of Cancer Survivorship. We are delighted that we were able to engage Dr. Yabroff, who will speak to us today on financial hardship associated with childhood cancer. Thank you.
Thank you, Dr. Hudson. While that is starting, I want to say how happy I am to be here to speak with you about such an important topic, financial hardship. And I also will mention that I had the pleasure of visiting St. Jude in Memphis a couple of years ago and was really impressed with the work that you all are doing. So I'm, again, very happy to be here to speak about this topic. So I'm going to try and cover a lot of ground. And I want to give you a quick overview or a roadmap of what I'm going to be talking about today. I want to start by defining medical financial hardship. People sometimes also refer to this as financial toxicity. I'm going to summarize some research findings in adult cancer survivors, and that's where the majority of the research has been conducted to date. Describe emerging research in adult survivors of childhood cancer, and then I really hope to have a lively discussion about research agenda going forward. I plan to leave plenty of time for questions at the end, but if there are any urgent questions, please feel free to submit them through the chat. So as background, something that many of you are aware of, there are about 17 million cancer survivors in the US, and it's projected to increase by about 20 million to about 20 million, by 2026, meaning that anything that happens with cancer survivors is especially important for the healthcare system in the US. As many of you know, cancer survivors can experience lasting effects of both disease and its treatment, including risk for new cancers and other chronic conditions, high healthcare spending, and limitations in the amount or kind of work. And this is something that's especially relevant for financial hardship because individuals who are limited in the types of work they can do may also face income loss and, importantly, loss of access to employer-sponsored health insurance coverage. And that is the main insure for the working age population under age 65. Additionally, compared to adults without a cancer history, cancer survivors are more likely to report high out-of-pocket burden, filing for bankruptcy protection, distress and worry about medical bills, delaying or foregoing medical care because of cost, and worries about daily financial needs, including things like food and housing. And I'm going to share some more specific findings related to some of these medical financial hardships that patients experience. But first, I want to share with you a couple quotes from a study we conducted several years ago, where we asked patients about their experiences with financial hardship due to cancer. And this first patient says that they're still paying for debts accrued from co-payments or hospital bills not covered by insurance, and paying credit card debt that was accrued during my time out of work. Another cancer survivor describes having to let the house go back to the bank. After 20 years of home ownership, we had to file bankruptcy. Another cancer survivor describes paying most of costs out of pocket. He says, most of my savings were wiped out, and now I struggle and I'm shamed by my lack of funds. I don't know that I'll ever recover financially. It's a considerable stress. And then finally, something a little bit different, which is someone who stayed with a company that provides excellent health benefits rather than seeking higher paying jobs where the benefits may not be as good. This is something we frequently refer to as job lock, where people stay with jobs because of health insurance coverage. So this study was conducted in 2012, and since that time, there have been a number of recent trends that affect the risk of financial hardship, including increasing cancer treatment cost, greater treatment intensity with more patients receiving treatment, receiving more combinations of treatment and for longer periods. And now we have many more types of treatment that are actually maintenance rather than a first line type of treatment. Additionally, many cancer patients, as they're receiving treatment, receive supportive agents, which can also be expensive. There's also been a number of changes in health insurance coverage over the past decade. Increasingly, we have something called a high deductible health insurance plan, which is where patients and their families must pay a deductible before health insurance actually starts. So prior to the point where they meet the deductible, they pay the entirety of their healthcare costs. There's also been some changes in patient cost sharing, and I have in parentheses among the insured, and I'll talk in a minute about the uninsured. But so co-payments for specific services have been increasing in recent years, and that's a flat fee based on the price of a specific service or for a specific type of service. And then co-insurance, which is a percentage of the list price of a service. And so, for example, $100 service with a 10% co-insurance would be $10, but a $100,000 service with a 10% co-insurance would be much higher, of course. And this is especially important when we think about oral prescription drugs, most of which fall under the specialty benefit for cancer patients. And then relatedly, despite a historic decline in the percentage of individuals who reported being uninsured following 2014 and 2015, the percentage of uninsured has begun increasing again. And we also are seeing a number of individuals who report having health insurance, but not being able to afford care. And we refer to this as underinsurance. And then finally, something that I think is going to be really important going forward, thinking about financial hardship, is the COVID-19 pandemic with widespread unemployment and adverse effects on access to health insurance coverage. And importantly, this is not affected all populations equally. It's had greater effects on populations that can least afford to lose their jobs or access to health insurance coverage. And so to give you a sense of what I mean when I talk about increasing costs, I want to shared these data about the monthly and median cost of cancer drugs at the time of FDA approval. And I think it's really worthwhile to note that in the 60s and 70s, the median monthly price was somewhere around $60 a month. And then we move into 2000s and we start seeing increases, several drugs above $20,000 a month. And now we're increasingly seeing drugs of $40,000 a month or more. And so I think it's really important to think about that co-insurance I mentioned earlier, what 10% of $60,000 a month might look like for a patient and their family. And that's, of course, for patients with health insurance coverage. So to put these increasing drug prices in context, I want to share some information about what's been happening over the same time period for median monthly household income. So these are mostly the same data. We see from the 70s to 2014 a nearly exponential increase in the median monthly price of new cancer drugs. This is at approval, but the median household income has remained flat. So for patients that are actually taking these drugs, it is increasingly a burden in these later years where the drug price is so much greater, median monthly drug price is so much greater than median monthly income. So now I'm sharing with you a framework that a colleague and I developed, borrowing heavily from the disparities literature. The idea behind it is thinking about how to measure financial hardship, but also how to intervene to address it. And so we have here material conditions, and these are things like having high out-of-pocket costs or having trouble paying medical bills. Psychological response, which is the distress and worry related to a financial position. And then coping behaviors, these are the things that patients and their families may do as a result of these high out-of-pocket expenses. So things like delaying or foregoing care because they can't afford it. In this slide, I'm sharing with you national estimates of financial hardship in adult cancer survivors. And this is from a nationally representative survey conducted among cancer survivors, many of whom were at least 5 years following their diagnosis. So about 7% reported that they had to borrow money or go into debt. About 2% reported filing for bankruptcy. 12% reported being unable to cover the share of the cost for medical care. About 9% reported other types of financial sacrifices, things like foregoing large expenses. And then if we look at all of those together, about 20% reported any material financial hardship. So this is a summary measure of all of these other measures of material hardship. And then we had only a single measure of psychological hardship, and about 23% reported any psychological hardship. In this next slide, I'm showing you the same data, but it's stratified by age group. And one of the reasons we selected this 18 to 64 age group and compare it to the 65 and older is to reflect differences in employment, but also importantly, differences in age eligibility for the Medicare program. So more than 95% of adults 65 and over receive insurance coverage through the Medicare program. But what you see here is if we look at that summary measure of any medical hardship, nearly double, more than double of the younger population reports any material hardship compared to the older population, which is about 14%. And about 32% of that younger population report any psychological hardship compared to about 15% of that older group. There are definitely many reasons for why hardship is greater in this younger population than the older population, including things like greater treatment intensity, different types of cancers. But I think it is really important to see this higher prevalence of hardship in the younger population, despite lower prevalence overall of chronic conditions compared to other chronic conditions compared to an older population. And I think it really reflects the protective effects of having Medicare insurance. This next slide, same data, but now I'm showing you by type of health insurance coverage, and I'm showing you the prevalence of material financial hardship by age group and type of health insurance. I want to start with this older group where we have Medicare only, Medicare and other public, and Medicare and any private. And this is the most common type of health insurance coverage for this elderly population. Very little difference in reporting medical financial hardship. But when we look at the younger population, we see much higher prevalence among those with public health insurance coverage and those who are uninsured, nearly double of the population who report any private coverage. But importantly, nearly 25% of those with private coverage still report material financial hardship. And so when we think about what that means for cancer survivors, this is a slide showing some data related to the amount of debt among cancer survivors with any debt. So the majority report less than $10,000, 45% report less than $10,000 in medical debt. But unfortunately, nearly 13% report $50,000 or more in medical debt. And 12% report between $25,000 and $49,000 in medical debt. And to put this information in context, I think it's important to think about a recent study conducted that showed that most Americans are unable to afford an unexpected expense of $400. So this amount of debt is substantially greater than what many Americans report being unable to afford unexpectedly. In this slide, I'm showing you information about the types of out-of-pocket spending among cancer survivors. And this is among those who reported borrowing money or medical debt. So not surprisingly, almost all report medical expenses, but nearly 60% report transportation and more than 20% out-of-pocket expenditures for lodging. And these types of expenditures that are directly related to medical care, but not about the medical care itself, are really important to consider, especially for patients who may be traveling farther for care. This slide that I'm sharing is from the earlier study I mentioned, and now I'm looking at psychological financial hardship. And we also find that it varies by age and type of health insurance coverage, with the highest proportion reporting worrying or having psychological hardship among the uninsured. Again, even among those with any private coverage, more than 25% are reporting having psychological financial hardship. And then finally, I'm going to talk about that last domain, behavioral financial hardship, that delaying or foregoing care because of cost. And in this study, I'm sharing, in this slide, I'm sharing data from a study on prescription drug use. And we compared adults with and without a cancer history. And we looked at different aspects of cost-related prescription drug non-adherence. That's a little bit of a mouthful, but here are the individual measures that are used for that measure. The green and red bars reflect cancer survivors. The green are longer-term survivors. The red are more recently diagnosed. The blue bar reflects those without a cancer history. And here you can see that cancer survivors are much more likely to report delaying filling a prescription, taking less medication, or skipping medication doses. So these are all aspects of behavioral financial hardship. And so as we were, building out this body of research, one of the questions we had was, what does that overlap look like? What is the intensity of medical financial hardship? And so we looked at many of those domains collectively. So this slide may be a little confusing, so I'm gonna walk you through it. So among the three domains, material, psychological, and behavioral, this would be anyone who reported all three of those domains would be in this red group here. So we found that 14% of cancer survivors reported all three domains compared to 10% of those without a cancer history. 21% of cancer survivors reported two or more, compared to about 19% of individuals without a cancer history. And I should note that these estimates adjust very tightly for things like age, health insurance coverage, socioeconomic status, gender, many other measures. So we are seeing greater intensity of financial hardship among cancer survivors compared to those without a cancer history. And in this next slide, I'm showing similar data, but focusing only on cancer survivors to dig in a little bit and look at the effects of health insurance coverage. So this is again among cancer survivors age 18 to 64, and these are national data. Red reflects multiple types of hardship. Green is a single type of hardship, and this clear color is no hardship at all. So I want to start with the group who are uninsured. 87% of this group report at least one type of hardship. 68% report multiple types of hardship. Another way of looking at it is that only 13% don't report any hardship at all. Importantly, if we look again at this group with private health insurance coverage, which is the group we would expect to be most protected against financial hardship, 65% report at least one type of hardship, and only 36% don't report any hardship. So to summarize what I've mentioned so far, we have different aspects of medical financial hardship: material, psychological, behavioral. We found that financial hardship is really common, and even many years following cancer diagnosis and treatment. And that out-of-pocket spending for healthcare is more than healthcare services. It includes transportation and lodging and other types of things related to receiving healthcare. And also, two factors that are most consistently associated with financial hardship are age and health insurance coverage. And as I mentioned, this really is an area of research that is, I would say, exploded in the past couple of years. And there's accumulating research on medical financial hardship in adult cancer survivors. And what we're seeing is large disparities in risk and prevalence of financial hardship. Factors related to age, which I mentioned already, geography, some evidence that there is more hardship among rural residents, socioeconomic status. There are multiple ways of measuring this, but just across every measure, we consistently see those with lower educational attainment, lower income, those who are unemployed or unemployed because of their cancer. They're much more likely to report financial hardship, race, ethnicity, and health insurance coverage, which I've given a little bit more detail about. We're also starting to see some research showing that financial hardship is associated with worse health-related quality of life and increased mortality risk. And one of the really big concerns is this potential for widening disparities in outcomes for cancer survivors. So already we see disparities in mortality across many of these factors: age, geography, socioeconomic status, race, ethnicity, and health insurance coverage. But with growth in financial hardship, the concern is that these disparities may widen in the future. So now I want to talk a bit about adult survivors of childhood cancer. And as I'm sure, and much of this research has been conducted by many on this call today, dramatic improvements in survival rates starting from since the 1970s. And we do know that survivors of childhood cancer have much higher risk of chronic health conditions, work limitations, challenges in obtaining health insurance and life insurance, more hospitalizations, and higher medical out-of-pocket costs. But there really has been less research addressing financial hardship. And I will mention that I started to add a little box at the bottom to reference some of the what we know about health conditions, but it would have been an entire slide all to itself. There's a lot of research on those topics, but much less related to financial hardship. And so now I'm sharing some data from a study we did a couple years ago, looking at productivity losses among adult survivors of childhood cancer. I think it's really interesting to look at because, as I mentioned earlier, challenges with the ability to work are related to reductions in income and also lack of access to employer-sponsored health insurance coverage. So these are data from nationally representative survey using multiple years. And here you can see that cancer survivors who are in green and adults without a cancer history in blue, that cancer survivors are much more likely to report being unable to work, less likely to report being employed in the past 12 months, much more likely to spend many more days in bed and more days lost from work. And when we apply a wage to this to get a sense of what this means in terms of lost productivity, we estimated that the annual per capita productivity loss was nearly $8,200 annually in cancer survivors compared to closer to $3,100 annually in adults without a cancer history. So it's a really big difference. And now I'm sharing some data from a study that was conducted from the Childhood Cancer Survivor Study. And this study looked at financial hardship in survivors of childhood cancer. And I picked out three elements that were evaluated in part because these closely reflect those domains I mentioned earlier: the problems paying medical bills, which is an aspect of material financial hardship; worry about affording medical bills, which is related to psychological hardship; and deferring care for a medical problem, which is related to psychological hardship, behavioral hardship. And here you can see the survivors, again, are in green. And they're stratified by those with high out-of-pocket expenses related to household income and lower out-of-pocket expenses related to household income. And you can see that those survivors with high out-of-pocket expenses related to household income are much more likely to report problems paying medical bills, being worried about affording medical bills, and deferring care for a medical problem. In the next slide, and this is a study led by Dr. Ai-Chan Huang, using data from the St. Jude Lifetime Cohort Study looking at medical financial hardship. And in this study, they found the impact of cancer and 22% of the population reported impact of cancer on a financial situation. Again, similar to that material aspect of financial hardship. 51% reported concern about ability to pay for healthcare or medication expenses related to that psychological hardship, and then 33% reporting inability to see a doctor or go to the hospital because of finances. That, of course, is related to the behavioral aspect of financial hardship. And they found consistent associations with lower socioeconomic status. So again, what is the intensity of medical financial hardship? I think that's a really important question. And the same study led by Dr. Huang also looked at intensity of medical financial hardship and found that about 9% reported all three domains, 23% reported two domains, and 33% reported one domain. In other words, only 35% didn't report any domains of medical financial hardship. I will note that that study was limited with the number of questions that address those different domains. So in this next slide, I'm sharing some unpublished data using the National Health Interview Survey from 2011 to 2018. I thought it would be interesting to compare with the St. Jude for Life study, which is in this bottom row. In this row, these are adult survivors of childhood cancer from the National Health Interview Survey, which actually looks pretty similar to the adults without a cancer history. Some important differences, though. The St. Jude for Life study was conducted in a fairly large sample of thousands of adult survivors of childhood cancer, whereas in this National Health Interview Survey, we combined more than 10 years of data and wound up with closer to 300 adult survivors of childhood cancer, and of course, a much larger population of adults without a cancer history. Another difference between these two is in the National Health Interview Survey, there's a set of standard questions that are used to identify material, psychological, and behavioral financial hardship. So in thinking about some of the strengths and limitations of these two different studies, I think it's really important to bring up one thing, which I think is going to exponentially increase our ability to conduct research in this area. And this is the Childhood Cancer Survivor Study Follow-Up 6. It has a number of questions related to financial hardship. So it was fielded in 2017 and 2019. It was completed by more than 4,000 survivors and more than 1,000 siblings. It includes multiple measures of medical financial hardship in material, psychological, and behavioral domains. And I will say I was fortunate to be involved in the planning committee for this. And so we ensured that the questions are comparable to those in national surveys, which will allow us to compare measures of those in the CCSS to other surveys like the National Health Interview Survey. It also included a number of measures of non-medical financial hardship, food insecurity and housing instability, as well as questions related to health insurance coverage, which, as I've noted previously, is one of the strongest drivers of risk and prevalence of financial hardship. And of course, it's a very large cohort of survivors with detailed information about cancer diagnosis, treatment, and multiple measures of hardship. So to summarize what I've shared with you so far about some of the research related to financial hardship in adult survivors of childhood cancer, we also find the same aspects of financial hardship as we did in adults. We also found, or several have found, lower socioeconomic status is strongly associated with hardship prevalence. So now I'm going to spend a little time talking about developing a research agenda. And I think the time is really right now for thinking about financial hardship, not only how to conduct research, but also how to conduct research in terms of how to evaluate it, but also how to intervene. So there's a number of questions related to measurement, including things like, what is the optimal timing of measurement? Should it be at diagnosis and after? And how many times, how frequent should it be? And who should be measured? And when we think about measure development, what is clinically, we don't really know what is clinically meaningful. And that's something I think will be really exciting to do going forward. I think we have a lot of challenges with data infrastructure in terms of having data on clinical details as well as other characteristics. Although descriptive epidemiology is not always as exciting as some of the intervention work, I will say that I think it's critical to have a better understanding of risk factors for developing financial hardship and having a better understanding of trajectory and being able to evaluate both incidence and prevalence. Much of what we know to date is related to prevalence, and we know less about the frequency of developing financial hardship. And I will say there was one abstract at ASCO that was presented last year that showed that among privately insured adults with metastatic colorectal cancer, that the hardship was cumulative. Around the time of diagnosis, maybe 20 to 30% reported financial hardship, which was measured as taking out debt, refinancing a house, or a loss of income of more than 20%. But by 12 months, nearly 80% of that population reported one of those three things: taking out large debt, refinancing a house, or having a loss of 20% in income. And that was in a population where nearly 100% had health insurance coverage. I think lots of need for research related to financial hardship and health outcomes, and interventions to address and reduce financial hardship. So I've seen out of the corner of my eye some really fantastic questions coming up in the chat, and I'm hoping that I will address them in the next couple slides. So I think it's really helpful to use frameworks and thinking about developing research agendas, but also in how to develop interventions. And so to date, most of what we know is related to the patient and the family, like what patient characteristics are associated with hardship. We know very little about the provider and care team and how frequently they even talk with patients about out-of-pocket costs. We also know very little about whether they talk about out-of-pocket costs. Many studies that have been conducted by inpatient populations report that a provider has not discussed potential out-of-pocket costs, but we know less about from the provider perspective. We also don't really know that much about local community environment and resources there that might be helpful, or things at the organization or practice setting. So things like patient navigation has been receiving a lot of attention recently, but we don't really know how effective patient navigation can be. I will say many of the projects that have been conducted to date have not been in the settings where financial navigation is most needed. And then finally, a lot of thinking about the state and national health policy environment. What are those factors and what are those interventions at each level? So one thing I think is really important to consider is the employer, because employers provide the majority of health insurance coverage to the working age population. And they make decisions about what insurance to provide, and they also make decisions about whether or not to provide paid sick leave. So I think there's a lot of potential there as well. So just to continue some of these thought experiments about what are these potentially modifiable factors at multiple levels. At the patient and family, how can financial and health insurance literacy be improved? And what is their role in informed decision-making? At the provider and team level, how can the team screen for, discuss, and address financial hardship? And also, can screening for uninsurance or underinsurance be improved? And who is the best member of the team to have these discussions? I don't think the oncologist is necessarily the best person to have these discussions, although they may want to introduce the topic and then have another member of the care team do that. At the employer level, what are incentives for offering workers comprehensive health insurance or paid sick leave? At the practice level, how can screening and documenting and addressing financial hardship, is this quality improvement measure? And can electronic health records include prompts and reminders that might help in this effort? And at the policy level, can health insurance coverage and benefit design be structured to minimize that risk of hardship, and then would further Medicaid expansion as part of the Affordable Care Act reduce financial hardship and improve outcomes? And I saw that there was a question about the Affordable Care Act, which is great because I have a number of, my final slides are going to be related to that. So as a quick overview, for those who are less familiar with the Affordable Care Act, have included a lot of different provisions, including a health insurance marketplace which allowed for individual purchase by families or small businesses. It included the elimination of exclusions for pre-existing conditions, annual and lifetime caps on coverage, and co-payments for some preventive services. It also included dependent coverage expansion, which allowed young adults up to age 26 to remain on parents' private health insurance coverage. There's a partial closing of the Part D donut hole for Medicare beneficiaries and state Medicaid eligibility expansions. And so just a quick overview of timeline. The Affordable Care Act was passed in 2010. Some of those early provisions, dependent coverage expansion, elimination of cost sharing, those rolled out in September 2010, but the majority of provisions were enacted in 2014, including Medicaid expansion in some states. So I want to share with you some recent research looking at state variation based on Medicaid expansion. And I'm going to be comparing neighboring states. And this particular study looked at the percent uninsured among newly diagnosed cancer patients. And so here we'd compare Tennessee and Kentucky, neighboring states. Tennessee did not expand Medicaid eligibility, whereas Kentucky did. And you can see in 2014, the percentage of uninsured newly diagnosed cancer patients was dramatically lower in Kentucky than in Tennessee. Something similar in Mississippi and Arkansas, Colorado and Utah, and also Oregon and Idaho. If we look at other characteristics of expansion and non-expansion states, I've got expansion states on the left, non-expansion states on the right, and this is stratified by income level, area level income or poverty among newly diagnosed cancer patients. You can see, and this purple is the highest level of poverty, you can see that diminishing disparities in expansion states, but not quite as much in non-expansion states. Similarly, if we look at race ethnicity, we see diminishing disparities in expansion states, but not so much in non-expansion states. These data are among cancer survivors, and we're looking at cancer survivors who report on insurance by income. And I've added a line here to reflect 2014, which is where the majority of the provisions happened. You see diminishing disparities in expansion states, not so much in non-expansion states. And in fact, you even see an uptick in uninsurance in non-expansion states among low-income populations. And this is the percentage of cancer survivors reporting care unaffordability. Again, diminishing disparities in expansion states, but not as much in non-expansion states. And so one of the reasons I think it's so important to be talking about Medicaid expansion again now is the potential for renewed focus on increasing health insurance coverage options with the new administration. And so this map shows you the status of state Medicaid expansions as of October 2020. And I want to draw your attention to the southeastern part of the US and then share a map of disparities in cancer mortality rates among males and point out that this is in 2002 to 2011. And this is before the Affordable Care Act and before any of those Medicaid expansions. And what we're seeing here is red, which reflects the greatest mortality rate, more than 243 per 100,000 in that southeastern part of the United States, compared to the blue, which reflects the lowest level, less than 200 per 100,000. It's something to think about as we move forward in the coming years and thinking about how to reduce disparities in cancer care and outcomes. And I want to wrap up by talking about the role of health insurance coverage and financial hardship across the cancer control continuum. And so for adults and adult survivors of childhood cancer who do not have health insurance coverage and experience financial hardship, they may be more likely to not have risk assessment or behavioral counseling, less likely to receive screening and evaluation of symptoms that are related to cancer. If they do receive screening, they're more likely to not have follow-up of abnormal findings or delayed follow-up, more likely to have underuse of effective treatment and lack of early inclusion of palliative care. They may be less likely to have coordinated survivorship care and lack of coordinated palliative care at the end of life. So with that, I want to thank you all for your attention and start taking some of those really great questions that I saw coming in. Thank you.
Robin, thank you. That was outstanding. There's lots of questions. Some are sort of aligned along the same theme of interventions and resources and, practical counseling of survivors. So can you address some of that in regards to what interventions have been tested or you think would be important objectives to test that can help prepare our patients and providers in systematically addressing hardship and helping survivors be able to overcome obstacles related to hardship?
Yeah, those are really, I mean, that's a really broad question. And I will say we're pretty much at the beginning of a lot of this research. There have been a number of studies looking at things like patient navigators. There's some educational interventions that are targeted to patients and survivors. My own personal bias is, and I'm going to go back to, oh boy, what I always call the onion. I think, many of these interventions that are directed to the patient and family, which are very important, affect one patient and one family at a time. Whereas as we think of these higher levels, we can have a much broader impact. And so, this is in part based on my own research interest, which is really, how can we formulate policy to try and address some of the challenges that patients and their families are having? But many things at the provider and team level, like how consistently are patients screened for financial hardship when they're diagnosed? And because I think it's a very dynamic situation. And like I said, there are this emerging research showing that the effects can be cumulative. And if anything, it looks like the risk of hardship increases farther away from treatment. And I think one of the concerns I have with some of the patient navigation that I've seen, at least, is they tend to focus very much on the treatment phase. And once patients are done with treatment, there may not be the same level of resources available to make sure that those patients and their families have access to health insurance coverage, but also any other community resources. There are a number of organizations. There are patient assistance programs for specific types of treatment. But again, those are very specific to the treatment. And if a patient is no longer taking that treatment, they may no longer have access to any of the assistance. So I think that's challenging. And at the same time, I'll just say that I think practices that treat the greatest population who may need assistance may have the least access to those resources. So I'm thinking of the federally qualified health centers and the safety net hospitals that are affiliated with those practices. I would say that is a place where we definitely need more focus, but at the same time, even patients with private health insurance coverage are reporting challenges with financial hardship.
Yes, you distinguish underinsured and uninsured as risk categories. And we've heard a lot, just even in the lay press and media, about how people, the disparities in costs based on your insurance negotiated coverage.
Mhm.
And for those that are underinsured, are you aware, or is it possible for them to actually negotiate costs like uninsured folks are to get a more reasonable rate? Or are they generally stuck? Is there anything? Are there policies that are seeking to address changes in that arena?
That's a great question. And I am not aware specifically, but I will say there's also been in the news some institutions that have reached out to patients who are, who are not able to pay their costs and have taken some of those patients to court. So I think, I think this is a really challenging situation, especially for patients who are underinsured. And when I say that, I mean like there are some of the high deductible health insurance plans have, I think the maximum deductible for a family of four is something like $12,000. And that's the maximum. But that's, you know, with many Americans reporting not being able to afford $400 in an unexpected expense, that's a little bit, that's more than a little bit out of reach. And not many people plan for a cancer diagnosis, so it's not like it's like people have a savings set aside for cancer care and its effect on the family.
So several questions actually are
Yeah.
asking, and you highlighted some of this in the talk, the differences in financial hardship between adult survivors of pediatric cancer and survivors of cancer diagnosed in young adulthood or older adulthood. I noticed the series of studies that you showed in
Mm-hmm.
survivors of adult onset cancer, you're distinguishing 18 to 64 and then 65 or older for obvious reasons because, they get it in the Medicare network. But there are other vulnerable groups that it would be great
Yes.
to have more data looking at that 18 to 26-year-old where they've been under now the umbrella with the ACA and having
Mm-hmm.
this coverage under a parental policy or expanded Medicaid, or even up to age 39 where boom, they're losing all that and still having hardships. Have you seen studies that have distinguished that? That seems like a knowledge gap that is worthy of exploration.
um, Thank you. That's a great question. And I will say I've had the good fortune of collaborating with colleagues on pretty much that exact study it is currently in press to look at that. But I agree completely. It is a very vulnerable population, that young adults who are diagnosed with cancer. I think especially because they are the population that has the most unstable health insurance coverage. And that is also the group where we're starting to see more working in what people call the gig economy, and they may not have health insurance coverage to work. And additionally, they may have a lot of fluctuation in their income. So that can be really important when you think about being eligible for subsidies under Marketplace, or whether or not they're eligible for Medicaid for reasons of income. And, just as an aside, most people with Medicaid coverage work, who are able to work. They work for employers who don't provide health insurance coverage. And they work for wages that are so low that they're eligible for Medicaid.
So there's another couple questions that are aligned
Yes.
related to assessment, risk prediction tools available to apply to predict cancer patient survivors at highest risk for long-term financial hardship. And this is also linked to a question about what resources can be available, practical resources in a busy practice that you can assess. Of course, when you assess, and you should really be responding and providing intervention. So sometimes that's a challenge there too. As you said, it may not be the oncologist who's dealing with this, or who's actually equipped or is trained to do this, but it would be nice to know tools and resources that at least put it on the radar of, I know this patient is struggling,
Mm-hmm, mm-hmm.
or is at risk to struggle.
Yeah, I will say most of what I've seen to date has focused on tools like the distress thermometer, which is, I think, fairly limited for addressing for addressing financial hardship in a meaningful way, there's a question about problems with finances, something like that. But many practices use certain thresholds for intervention based on having a certain score on the distress thermometer. So I think this is an area where we need a lot of work, and I'm really hopeful that some of the research coming out of the CCFS, that follow-up study, will help us to identify high-risk survivors, or survivors who have high risk for financial hardship.
So there's other questions, Robin, that address, how do we compare to countries such as Canada or other countries in Europe, for example, that have national health plan coverage? Are there studies that evaluate that? Are you familiar with them that you could?
There are.
I guess we could sit here and be more depressed about we're not measuring up.
Well,
I'd love to hear your opinion.
Yeah, no, I mean, there are some, and I will say I worked with a colleague from Canada and other colleagues from Ireland over the summer on a study looking at financial hardship outside of the US. And it happens, but it's not nearly as severe or common as in the United States. I will also say, like, one thing that's kind of interesting about Canada is and the insurance varies by province, but also my understanding is that there is not coverage for oral prescription drugs in the same way there is for infusion prescription drugs. And so that is increasingly, from what I've heard from colleagues, that can increasingly be a problem, that for patients who receive oral prescription drugs or oral chemotherapy biologics, that they may be more vulnerable to financial hardship than others receiving infusion drugs. But I mean, overall, this problem is not unique to the United States, but it is something where it's much more common in the United States, and it's also more severe when it happens.
We're right at the top of the hour, so I'd like to thank Dr. Yabroff for her excellent talk. And to close the official event, we still have some questions that have not been addressed in the chat box. So Dr. Yabroff has agreed to stay for a little extended discussion. We hope you will as well. I thank you again for coming, and please note that we have another survivor-focused lecture that will be given by Dr. Ann Kirchhoff from the Huntsman Cancer Center on identifying strategies to improve HPV vaccination. That will be on April 8th. So thank you again for your attendance, and those who would like to stay for the extended discussion, please do. Okay, so Robin, there is a question about what about genetic testing? Now that we are in the genomic space, how might that impact? Are there studies looking at the impact of genetic testing on financial hardship?
I think it's tricky in part because in some cases, especially academic institutions, the cost of the genetic testing itself can be covered, not necessarily through health insurance, but through, data collection efforts from organizations that are developing those tests and the related treatment. It's not clear that the out-of-pocket costs for the treatment are covered in the same way, but in some cases the testing is covered. And I will say that a couple of years ago, I did a study. It was a survey of oncologists specifically it was about genomic testing of any sort. And when I was at the National Cancer Institute, I managed to squeeze in a couple questions about whether the oncologists talked with their patients about out-of-pocket costs for genomic testing. And it's not that surprising that most did not. And the things that were strongly associated with whether or not they did talk about genomic testing were related to their specialty. So if they mostly saw solid tumors versus blood cancers, not surprisingly, but also some of the patient characteristics. So if they tended to treat patients, if they tended to treat more patients that were uninsured or underinsured, had Medicaid, they were more likely to have these discussions about expected out-of-pocket costs. But I think it's a really difficult conversation, and it's I think a lot. My own personal opinion is that trying to estimate down to the dollar how much a patient should expect to spend out of pocket, I think that's nearly impossible. I think probably a more achievable discussion is, are the expected out of pocket expenses going to be closer to a cup of fancy coffee, for your tuition at a private institution, or a small mortgage? I mean, I think like some relative range can be especially helpful in thinking about how to have those discussions. I think, and I'll also say, I think that discussions are really important, and having a discussion or screening for financial hardship in the absence of being able to do anything about it, I think is also challenging on multiple levels. So I'm not throwing my hands up, but I am trying to say there's a lot of work to be done.
Okay, there's a question. Can you elaborate on how income flow for those who may be disabled due to cancer, in which case like steps parents or guests, partners or caregivers can take to position to buy lifetime insurance coverage for children with cancer? Any thoughts about that? Or how can families be proactive, I guess, if they anticipate that there will be some impairment and hardship in the future based on the effects of cancer or the cancer or its therapy? I think that's what the question's getting at.
Yeah, that's a really great question. And I will say it is not something I know much about. I think, I think, there are many practices now have highly skilled social workers who are very familiar with all of the ins and outs of different programs. And to the extent someone can qualify for disability and Social Security, I mean, those are the sorts of resources that come to mind quickly. And I am not as well versed in specific resources, but I'm also happy to provide. I know the National Cancer Institute has like a number of different organizations. There's like what people call a web farm or a link farm of different organizations that help. And I also know that the American Cancer Society does provide some assistance in that area as well.
So it's interesting that we're talking about long-term hardship here, and there's actually some very provocative comments or statements. Should an accountant, money manager be part of the survivorship care team? Wouldn't that be great? But actually, how that type of partnership or perspective on your survivorship care team can help prepare survivors to address and be proactive about potential financial hardship. And so this person who is offering this question also says that their institution, they focus on education, vocational attainment, hoping to offset the financial hardship. And so they're teaching basic financial health like checking, savings, credit card, and that it relates to, these are interventions actually we could test in our population to prepare them at transition. Do you have some thoughts about what interventions would have the biggest bang for the buck that we can do during treatment or off therapy? What targets potentially, and even into long-term survivorship? No pressure here.
Okay, great question. And I think, there's a number of things that are related to financial health literacy, health insurance literacy, like those sorts of things are super important for patients and families, especially when selecting, if they have the option of selecting between different types of health insurance policies. And, I will say, I think just about everyone could benefit from some of that because, many people I know, colleagues, either who treat patients or do research, there's some confusion between co-insurance, deductibles, premiums, and premiums, which is the monthly amount you pay for your insurance. The reason people have these high deductible plans it's because the premiums are so much lower. And so there's this trade-off. And so making sure that people fully understand what trade-offs they're making when if they have the option to choose health insurance, the trade-offs people are making between low premiums and high deductibles, like that's what that means. But at the same time, knowing what happens with co-insurance and co-payment is really critical. And then there may be some cases where having a high deductible plan that it's accompanied by something called a health savings account, which allows people to put money into an account pre-tax. So it goes a little bit further and it can accompany a high deductible health insurance plan. That's really important too. So I guess I'm making the argument for interventions related to health literacy, health insurance literacy, and financial health literacy as part of survivorship care planning. Go ahead.
No, I was saying it's interesting. We're struggling in countries with really good resources, and we actually have participants on the seminar who are from low and middle income countries where survivorship care is really in some places just emerging, and people are paying for out of pocket. All these costs are out of pocket, and they need they need assistance as well, and targets and how to prepare their families for lifelong effects of cancer that potentially may pose hardships in the future. So I think that we have problems, but I think we need to recognize that this is as we're increasing cancer rates globally, we need to think about low and middle income countries and how we might be able to facilitate reducing hardship in that area as well.
Yeah, I think that's an excellent point. And when I said that it's more common and more severe in the U.S., I think I should have said that I'm comparing to other countries that are higher resourced countries and not the low and middle income countries. And I will also say we can compare in countries where we have those data. I've seen less data in low and middle income countries where I have seen data from other, Canada, other European countries.
What funders support this type of research, in behavioral intervention research, to promote health literacy and facilitate the access to resources and whatnot, understanding and adherence to be able to find resources and adherence to care? Or can you suggest or offer your experience in being able to access that type of funding for this type of research?
Yeah, no, it's a good question. And I think especially I have the advantage of having formerly been at the National Cancer Institute. And I can say that this is a strong area of interest from the National Cancer Institute. And I think there are a number of, what is it called? NOCI, where they've sent out notice of interest. I know there's one related to oral prescription drugs. And I think there are several others. I know medical financial hardship is something of great interest to the NCI. Also, there are a number of foundations that have a lot of interest in this area. Things like Robert Wood Johnson comes to mind quickly. I've seen some work funded by the Commonwealth Fund, not always cancer specific, but they do tend to have research in this area. And Robert Wood Johnson funded a couple years ago a series of projects related to cost of care discussions, like what's the important component and and to provide information for providers in having these discussions.
Yeah, I think there's some comments about, and a lot of these are comments that probably your opinion is of interest, but we know that you don't have the magic answer. But how do we balance increasing cost and research and development that go into creating new drugs and this hefty price tag with affordability that then leads to long-term financial hardship? You know, do you see things happening on a policy level, nationally or statewide, et cetera, that will help us get over this obstacle? I think it's more of an issue actually in the United States than it is in other countries, but with the way our healthcare system is organized.
Yeah. And I will say, okay, so now we're going to move into my own personal opinion. Like,
okay, that's fine.
Yeah, like I think we have a lot of challenges in, one thing, we cover a lot of different treatment. And so I know, and I, as a non-clinician, I know that prior authorization can be very difficult. And, there are patients who do require non-standard drugs. But I think one of the challenges is, there's a lot of challenges. I think I'm not even sure where to start when I start talking, at the question about what all the challenges are. We, typically the federal government is not allowed to negotiate on what it pays for prescription drugs. Healthcare overall is very expensive in this country, in part because it's so fragmented. And, we have, a single clinician may have patients with hundreds of different types of health insurance coverage, even though they may have the same plan. It may be a different product within that plan. So it may be different levels of deductibles, co-pays, co-insurance. So all of this creates extra work, and I'm not going to, it just creates more burden. So we do spend in this country a lot of money on the fragmentation. And then, also when people without health insurance coverage are hospitalized or they go to the emergency room, ultimately we all pay for that. So that is reflected in higher costs for some services. I think it's just, I don't want to just say it's really complicated and leave it at that, but it is really, really complicated. And the challenges are different in different parts of the country and for different patient populations. But I think, I will say, I think this is a really interesting time, in part because I think we are getting to the point very soon where we have to do something. Like, so I think it's, when some politicians talk about kicking the can down the road, I don't know that we can keep kicking the can down the road in relation to financial hardship. And one of the things I really worry about is that we will start having rationing of care, and it's going to be based on ability to pay. And that's something really troubling to me specifically, that this idea that people will not be able to get care that they need because they can't afford it. And even if they have health insurance coverage, they still may not be able to afford it. So, yeah.
So a sobering comment, but I think that even among countries with national health plans or countries that have more limited infrastructure, like low middle income countries, we're all struggling with the financial hardships that our survivors are experiencing. So we really appreciate your insights and your willingness to have stayed for this extended discussion. I think I've hit most of the questions in the chat box, other than lots of people saying great job and how much they enjoyed the lecture and want to be able to access it, the lecture is online at St. Jude, so you can check at the registration site. But Robin, thank you again. This was just excellent. We really learned a lot from your lecture, and we have lots of research targets to be focusing on for the future.
Yes. Can I, before I sign off, can I ask to get a copy of the chat? Because there are so many great questions.
I actually just got it. We got it.
Oh, perfect.
Okay, very good.
Yeah, it's such a great way to hear the questions that people have, and it always gives me ideas for research too.
Okay, well, thank you again, and everyone, at least in our neck of the woods, stay warm as the snow is hopefully going to be melting soon, and other places have a good evening or good day as you're starting, okay? Okay, take care, everybody.
Thank you.
Yeah, thank you. Bye-bye.